Good morning, everyone. Welcome you all to the fifth MVR CanCon. So here today we have with us a very special guest, Dr. Ivan Jacob Lipson. So he is a consultant medical oncologist at Johns Hopkins Hospital, and his specialty is mainly in cutaneous oncology and clinical immunotherapy. So welcome, Dr. Ivan.
Thank you. It's great to be here.
So let's talk a little bit about your field of interest. So let's come to cutaneous malignancies as such. So what is the incidence of cutaneous malignancies that you see in your place and in the country as such?
Well, in the United States, there are about 100,000 new cases of melanoma every year. And then beyond that, there are several hundred thousand non-melanoma skin cancers. So we see both. We see a combination. I would say half of our practice is melanoma, and then the other half is non-melanoma skin cancer.
So if you want to break up between melanoma and non-melanoma, so what would be the exact percentage of melanoma among the total incidence of skin cancers?
But among the total incidence, the non-melanomas are much more common. There are millions of basal cells and squamous cells, et cetera, in the United States every year. There are many fewer melanomas, but in terms of mortality, melanoma is much higher.
It ranks above the other two.
Than basal,
Yes.
yeah.
And regarding the stages, so what stage is more common there? Do patients present to you with an earlier stage, or you often see metastatic diseases?
We do often see metastatic patients, although I will say that in general, the more common patients with melanoma present at earlier stages are seen by dermatologists. They get their melanomas, their thin melanomas removed, and most of them are cured. By the time they get to us, they're stage 2, stage 3, stage 4. That's much less common, but in our practice, that's the majority of our population.
And so regarding your frontline treatment for metastatic melanoma, so what regimen are you most comfortable with in a patient?
For most patients with metastatic melanoma, we're using combination immunotherapy. And so generally that involves either CTLA-4 and PD-1 blockade, that's ipilimumab and nivolumab, or LAG-3 plus PD-1 blockade, that is relatlimab plus nivolumab, or as it's put together in one, the drug is called Opdualag.
So what is the percentage of patients who have access to this triple therapy, nivo plus relatlimab plus?
In the United States, that's close to 100%. By and large, the patients that we see have medical coverage in some way, and when costs become too high, we work with the patient and the pharmaceutical company to make sure everybody is covered.
Okay, so that is not the case, at least in a country like India. So if you take around 100 patients of metastatic melanoma, only around 15 to 20% of patients, they have access to nivolumab plus ipilimumab in a frontline setting.
Is that because of financial resources?
Yes, plus majority of the drugs, they're not covered under the insurance.
I see.
Yeah.
I see. Okay.
And so let's come to your talk in general. So your talk is basically based on salvage therapy in anti-PD-1 refractory melanoma.
Right.
So what is the exact incidence of anti-PD-1 refractory melanomas? So
Good question. So for patients that receive an anti-PD-1 based therapy, approximately half of them, give or take, are going to be refractory in some way. So the good news is that means that about half of patients have prolonged durable responses, but that does mean that the other half of those patients need some other therapy. So one possibility is that if a patient has started on a particular combination of therapy, ipilimumab plus nivolumab, for example, you can switch to the other combination of therapy, so Opdualag. Another possibility is that we get out of the immunotherapy family altogether and we switch to a targeted agent. So for a patient with a BRAF mutant melanoma, that means BRAF plus MEK inhibitor, or a c-KIT mutant melanoma, that means imatinib or a drug like that. And then more recently, there has been an FDA approval of a drug called lifileucel, which is a TIL therapy.
TIL therapy,
Yeah,
yes.
tumor infiltrating lymphocyte therapy. So,
and I presume the trial has been, they have compared the TIL versus ipilimumab, right? And it was shown to have
yeah, that was a separate study
separate.
that was done in Europe by John Hannon and his colleagues. But the agent that's been approved in the United States, that's a commercially available TIL product, and that's used for patients who have already had anti-PD-1 based therapy, plus or minus BRAF therapy. And so that's a third
And
option.
currently it's been FDA approved.
Yes, yes.
So if you see a patient upfront, so are there any parameters to suggest that this patient might be anti-PD-1 refractory? Is there any clinical, laboratory, or any other pathological correlates to see if the patient will not respond to immunotherapy?
There are suggestions in the literature about interferon signatures and PD-L1 expression, and there are lots of different investigations and some hints. But at the end of the day, we can't point to a feature of a tumor and say, this tumor is not going to respond to anti-PD-1 based therapy.
Okay, got it. So in your clinical practice, suppose if you are starting a patient upfront with an anti-CTLA-4 plus an anti-PD-1 and the patient progresses, so what is your go-to regimen? You shift them to an different anti-PD-1, for example, pembrolizumab plus ipilimumab combination, or you go to nivolumab plus relatlimab, or you would add an anti-LAG3. So what is your...
We don't generally switch to another anti-PD-1. That hasn't been shown to be effective. So if somebody has progressed through IPI plus Nivo, we'll switch them over to Opdualag, Rela plus Nivo, relatlimab plus nivolumab. And the opposite is also true. If somebody starts on relatlimab and nivolumab,
You switch to
we switch them to IPI plus Nivo.
Okay, I think that is based on the relativity O20 study that showed a benefit with Nivo plus Relax.
That's right.
So thank you, Dr. Lipson, for your time.
It's my pleasure. Great to be with you.
Thank you.